Thank you so much for having me today. I'm going to be speaking about updated recommendations for SARS-CoV-2 vaccination. Here are my conflicts of interest. I've been a clinical investigator for trials funded by Vir, Regeneron, Gilead, and J&J, and I've been a consultant for Immunon and HOOKIPA and a scientific board member for Bavarian. In the last 4 years, we have administered almost 14 billion COVID-19 vaccines. This is a picture of the global map showing the share of people who've received at least one dose of a COVID-19 vaccine. There have been many regions where upwards of 90% of individuals have received at least one dose, but there are regions like in sub-Saharan Africa where that's been far less. This data that I'm showing here is actually about a year old. It's hard to find super updated data these days, but I suspect that it hasn't changed very much. And the reason why is because the number of doses administered has really plummeted for COVID-19. This is a figure showing daily COVID-19 vaccine doses administered. And in 2021, there was, say, 40 million doses given every single day of a vaccine. However, there's only been 51 million vaccines given in the last year, so less than 1% increase. And you can see in this figure, hopefully, that that's really a trivial amount that's not even registering, looks like a flat line. And so this is showing that even with last year's updated boosters and new people coming out to get vaccines, there's really very few that have been given. Today, I'm going to be mostly talking about recommendations here in the United States and in the context of the United States, but as a reminder, COVID-19 vaccines really vary significantly across the world, and mRNA in particular is not everywhere. On the left, I'm showing figures from the US and the European Union, where about 1.4 billion doses of the COVID-19 vaccines have been administered. These bar graphs are showing the rough proportion of different vaccines that have been given, and the vast majority in both of these areas have been either Pfizer or Moderna, so mRNA-based vaccines. In contrast, if we look at the breakdown in India, which has actually given nearly twice as many doses of COVID-19 vaccines, most of those doses have been the adenovirus-based vaccine, so AstraZeneca vaccine. And mRNA doesn't even make it into the top 3 of the vaccines administered in India. As a reminder, so we never forget, COVID-19 vaccines have been estimated to have prevented 14 to 20 million deaths globally in the first year. Most of those deaths averted in that first year were in upper middle income and high income countries, but that certainly extended over the following year when the vaccines were more widely distributed. Things have changed a little bit. We're no longer a population of people who are totally naive to COVID-19. This is a figure showing the prevalence of COVID-19 antibodies in New York City from 2020 to 2022. And they're showing here that by July 2022, nearly 100% of individuals in New York were immune somehow to COVID-19. So either they'd been vaccinated or they were unvaccinated, but were infected, perhaps even multiple times, such that really everyone in New York, by 2022 had some pre-existing immunity to COVID-19. This is true outside of New York, of course, in multiple areas. This is one example figure from Ecuador, showing that there the antibody prevalence also went up to about 95% by 2022 of that population. And I just show here, I don't know the statistics on here, but to me, I'm questioning, are there hints of waning immunity seen? Perhaps we'll see when the data emerges from 2023. As far fewer people are getting vaccinated, obviously they're still getting SARS-CoV-2 infections, but one wonders if population immunity may start to wane. So the biggest challenge for both infections and vaccine development has really been the ongoing sequence diversity of SARS-CoV-2. This is a phylogenetic tree that is showing the relationship between the original Wuhan virus and the variants that emerged in the first year or so, showing how they've branched off from that original virus. So each of these branches is showing the diversity or the distance between that sequence and the original strain. So this is showing the branching off of alpha and then beta, and then the big surge of Delta viruses that were also a big branch point. And then in the end of 2021 into the beginning of 2022, we saw the big branch point into the Omicron sequences. And those have continued to branch off even further. And the distance now between the original Omicron strain and the most recent strains are as far or greater than the distance between Omicron and Wuhan. So what I've marked up here are really the biggest branch points for the Omicron substrains that are also of clinical significance or vaccine significance. So for example, in green is the big branch point of the BA.5 sequences. In yellow at the bottom is the branch point of XBB. And then over there to the right in orange and red are actually the most recent sequences, which are kind of under the umbrella of JN1 and include the sublineage of KP2. And that you could see is the farthest, and that's the most recent of the sequences. So I've kind of highlighted these three branch points, but they're also significant for vaccines because the original vaccine was based on the Wuhan strain. The 2022 vaccine incorporated the BA.5 sequence. The 2023 vaccine was based on the XBB sequence. And the most recent vaccines that that I'll be talking about today, the 24-25 vaccine, is based on the JN1 and sublineage sequences. But these sequences, they continue to diversify. This is showing the percent of viral lineages among infections. This is a CDC map. This is showing the proportion of these different sequences more recently, so April to August. So back in April, JN1 was dominant, but that has continued to diversify, which is really what I'm trying to show here, such that the more recent breakdown is showing KP2, KP3, LB1. Now, keep in mind, these are sublineages of JN1. They haven't yet, had a big branch point change. So they're all relatively similar to JN1, but that sequence diversity just keeps on going. So how does the US FDA anyway approach updating vaccines and vaccine composition? So this is a figure that the FDA showed in a meeting in June, where they outlined their approach. So they look at vaccine campaign X, let's say it would be last year's campaign, and they're really at that campaign reviewing the integrated data to see how it did from the prior year. So they look at what the manufacturers updated for that vaccine at that time, what the manufacturing data was, preclinical data, and then they look at the real world evidence of that updated vaccine effectiveness. How did that vaccine do last year after they updated it? And then they say, is there any change in the sequences that we need to be aware of? We need to look at that. How different is it from last year's vaccine? And then what are the manufacturers able to do? Can they update their vaccines? Do they have new data that they can show us? And then that will reflect what they advise for the next season. So for example, there's last year's season, the 23-24 vaccine. They'll integrate all that data, look at it in a big pot, and then make a decision about the 24-25 vaccines. So what I want to do today is just talk about two elements of this. The first is to look back at last year's vaccine and look at the real world evidence of updated vaccine effectiveness. And then to review that data, think about the sequences that have emerged, and then look at what the vaccine manufacturers have presented to the FDA about their new vaccines. So something to keep in mind when we're talking about the effectiveness of last year's vaccine is that, as I explained, population-wide immunity is very extensive. So about 100% of people have some immunity to COVID-19. So whatever we look at, when we look at the vaccine effectiveness, we have to keep in mind that that's the incremental effectiveness. So we're not going to see whopping numbers like we did in the early days of COVID-19. This is really, what does the updated vaccine add to the background immunity that people have? So here, they're looking at vaccine effectiveness of last year's vaccine compared to people who did not receive that vaccine. And those people who did not receive the vaccine might have got the vaccine the year before, or maybe they have had an infection several times. So all they're looking at is, did you get last year's vaccine or not? So this is data that I'm showing that was presented to the CDC or in the CDC meetings here in the US, pulled from various different surveillance networks. So the first finding is that the people who received last year's vaccine had 53% fewer symptomatic infections compared to people who did not receive the vaccine. These are people who presented to, say, CVS or Walgreens. These are pharmacies we have here, presenting to be tested. That immunity or that protection was found to peak about 2 months after vaccination and then started to wane, over the next 3 or 4 months. So this is in general, but then, what the FDA is interested in is like, what about more recently with the newer strains? And here they could compare vaccine effectiveness with non-JN1 strains, so the earlier strains versus likely JN1 strains, and found that the vaccine effectiveness against symptomatic illness with JN1 was lower. So it dropped from, say, 58% for the non-JN1 strains down to 37% for the JN1 strains. So not only is the vaccine kind of waning over time, but also waning against the more recent strains. People who received last year's vaccine also had protection against emergency room and emergency care visits, so 50% fewer visits to the emergency room compared to people who did not receive last year's vaccine. That peaked about 2 to 3 months after vaccination and then started to wane over the next 3 to 4 or 5 months. And when in this particular surveillance network, they were able to do sequencing so they could really say what was protection against XBB, which matches the vaccine, compared to the JN lineages that we see now, and found that the vaccine reduced that hospitalization rate, or the effectiveness was 54% against the vaccine match strain, but then that dropped down to 33% against the more recent lineages. So effective even in the setting of background immunity, but waning over time with the new lineages. Importantly, these vaccines have always been very good at reducing your chances of having critical illness. So people who received last year's vaccine had 69% fewer cases of critical illness compared to people who did not receive the vaccine. And we think about this as being most relevant to older populations or immunocompromised folks that are at highest risk of worsening to critical illness. And this effect was a little bit more, had a little bit more duration. So it peaked at, 2 months, but actually stayed pretty high for several months afterwards. And these vaccines have remained safe and well tolerated over the last year. These list of adverse events have really not changed in the last year. So common adverse events are injection site reactions and fatigue, headache, fevers, and chills. And then there's rare but serious associated events. Probably the most prominent is myocarditis with mRNA vaccines and possibly the recombinant protein. There's about 10 to 100 cases per million doses, mainly in young men. There's thrombosis with thrombocytopenia that's been observed with the adenovirus-based vaccines, and it's associated with autoantibodies, and there's about 4 cases per million. And then a loose association with Guillain-Barré syndrome with adenovirus-based vaccines at 3 cases per million doses. So looking at the vaccine effectiveness data, putting ourselves in the shoes of the FDA and looking backwards, first we have to interpret this data on the high background of population immunity. So updated vaccines will have only an incremental effect over the background. Nevertheless, the updated vaccine from last year protected against symptomatic infection, emergency department and urgent care visits, hospitalizations, and importantly, critical illness. Vaccine effectiveness was reduced against the newer JN1 lineages and also waned over time. And so these final pieces are really what supports the need for an updated vaccine, actually supports the need for a booster and that you update the booster. So now I want to turn to the data that the companies presented to the FDA on their updated vaccines. And when they did this is back in June, they only have preclinical data. So they're not doing those big efficacy studies anymore. They're just presenting preclinical or animal data to the FDA to show that their vaccines are anticipated to perform well. So here, Pfizer, for example, talked about their KP2 boost. So remember, we're now in the world of JN1, and JN1 has these sublineages that include KP2. So I just keep emphasizing that again because you'll hear about JN1 and KP2, and it's important to know that they're pretty related, these two. So they showed the booster effect if they boosted these mice with their original vaccine, last year's vaccine, versus a new JN1 or a new KP2 vaccine. So when they boosted the mice with the XBB vaccine, last year's vaccine, that's on the left, they didn't really get a great boosting response against what's all these other sublineages of JN1, the recent strains, and those are shown in all these colored bars. Whereas with the JN1 vaccine, and especially the KP2 vaccine, they were able to boost responses against all these new variants that are circulating. Moderna also showed data from a JN1 vaccine and a KP2 vaccine and compared it to looking at last year's vaccine. So this is data showing on the left where they boosted mice with last year's vaccine and found that vaccine responses were really poor, if not negligible, against the new strains. So boosting with last year's vaccine based on this data would not be very helpful against today's strains. Whereas boosting with their new KP2 vaccine showed, very nice boosting responses against JN1, KP2, and the other newer sublineages. Now, Novavax, they had a JN1 vaccine, and they showed data in non-human primates, and they showed really nice boosting responses. These are neutralizing antibody titers, not only against JN1, but also importantly, all these JN1 sublineages like KP2 that are now circulating. So based on that data, that preclinical data, the FDA approved or authorized the KP2 mRNA vaccines and the JN1 Novavax vaccine. And this was just in the last month. So the current US CDC recommendations endorse these vaccines that are updated with the 2024-25 formula. And these recommendations were actually provided in June of 2024 prior to the FDA approvals. And the big picture is that they really say everyone who's over 6 months old should be getting a COVID-19 vaccine. Specifically, all individuals who are 5 years of age or older should get 1 dose of the updated vaccine. And that's even if it's the initial dose. So if you have like a 14-year-old that's never been vaccinated, they come into clinic, they should just get 1 dose. So they made it very simple in that way. Individuals with immunocompromising conditions, they may get additional doses of the updated vaccine, and they kind of left that up to those individual providers. And they made this interesting note that an additional dose for people who are 65 years old or older, who are not immunocompromised, is not currently recommended. So I don't know if that will change over the course as they get data over the year, but right now they're saying just being over 65 is not enough to merit getting an additional dose unless you're immunocompromised. For the little kids, 6 months to 4 years old, they are recommended to get a vaccine, but how many vaccines they get really depends on their prior vaccination history. And then finally, for people who are 12 years old or older, who cannot or choose not to get the mRNA vaccines, the updated Novavax protein vaccine is an option. Now that is great. We have these new boosters. The data from last year looks like updating the vaccines and boosting makes a lot of sense. And now we have new lineages, but we've got an updated vaccine. But unfortunately, we still have a problem with our vaccine rollouts. And this is the cumulative percentage of US adults that were vaccinated in the last year. And you remember, like, that big figure shows is pretty trivial globally, but in the United States, it was also pretty low. So the vast majority of Americans never got the booster last year. But even in the most at-risk groups, so people who are 60 years or older, they barely reach 40% of those individuals who actually got the booster. So there's a lot of education that still needs to be done. And part of that has to do with people's perceptions. And this figure is just showing a bunch of survey results from US adults, showing that only about 20% of these individuals still think that COVID-19 is a major threat to either the health of the US population or the US economy. So I think there's a lot of education that has to be done for those at-risk groups, those older populations in particular, to say that for you, COVID-19 is still a risk, and that these updated vaccines, at least based on last year's data, can have a significant benefit for protecting against especially critical illness. So in summary, COVID-19 vaccination rates have really plummeted in the last year. The population immunity remains high, may be waning. We'll see when we get data from the last year. The updated vaccine from last year really protected against symptomatic infection and, importantly, severe disease. But last year's vaccine is less effective against the newer JN1 lineages. The new 2024-25 vaccines have been approved or authorized by the FDA, and they target the similar JN1 and KP2 strains. And the CDC recommends that everyone who's 6 months old or older to receive the updated vaccine. Thank you very much.